Hi, everyone. I'm Valerie Williams, registered dietitian in Philadelphia, Pennsylvania. I'm excited to be here today to talk with you about exocrine pancreatic insufficiency, or more lovingly known as EPI. So before we get into talking about EPI, I always like to start out with talking about the function of the pancreas. And we know that the pancreas plays a lot of roles in our body, but our patients do not. So I think it's always a nice reminder to think about what the pancreas does and also be able to verbalize that to your patient. So what we often think of the pancreas as its most popular function is the endocrine function, or glucose management, with the secretion of insulin and glucagon. But today we're going to focus more on exocrine function, or digestion, including the secretion of enzymes, bicarbonate, electrolytes, and water. So what is the role of the exocrine pancreas? It produces and excretes three main pancreatic enzymes: amylase for carbohydrate digestion, protease to digest protein, and lipase to digest fat. The pancreas, when it's working at its full capacity, has an enzyme secretion on average of 720,000 lipase units per meal in healthy individuals. That amount can vary dependent on content and volume of ingested food. So let's talk a little bit about the digestion of carbohydrates, proteins, and fats. Carbohydrate and protein digestion starts further up in the body and relies a bit less on pancreatic enzymes. Carbohydrate digestion begins with salivary amylase, and protein digestion begins with gastric acid and pepsin. Both are further digested by pancreatic and small bowel enzymes in the duodenum. Fat begins its digestion in the stomach with lingual and gastric lipases, but heavily relies on pancreatic lipase for digestion. And then the fat is emulsified by bile salts into micelles, which are absorbed in the jejunum. For more information and individual videos on macronutrient digestion, be sure to check out other DNS YouTube videos on carbohydrate, protein, and fat digestion. So what is exocrine pancreatic insufficiency, or EPI? It is the inability of the pancreas to produce or secrete pancreatic enzymes and bicarbonate for action in the intestine to achieve normal digestion and absorption. It results in food being inadequately digested and absorbed. And it is caused by alterations in several factors. Pancreatic stimulation. The pancreas is not being told to release the enzymes. Pancreatic enzyme synthesis. The enzymes are not being made, maybe because there's not enough pancreatic tissue or the tissue is damaged. The enzymes are not being transported appropriately, potentially not getting to the right place because of an obstruction or a tumor. And then lastly, alterations in the synchronization of gastrointestinal secretions, which could be that the emptying of the stomach contents does not match up with the enzymes coming over from the pancreas into the small intestine. And so patients may have EPI from one of these alterations, or they may have it from multiple alterations. Why does EPI matter? What are the consequences? There are consequences that are short-term and affect a patient's day-to-day life, and then there are bigger consequences that keep us as dietitians up at night. So a consequence of EPI is maldigestion of protein, carbohydrates, and fat. How I describe it to my patients is that they're eating their food, but their body can't break it down into parts that it can use. So the food is going unutilized, it's getting into the intestines and fermenting and creating GI distress. But ultimately, they're not using the food that they're eating. It can lead to micronutrient deficiencies, especially related to fat-soluble vitamins A, D, E, and K. And not using your food can lead to the known detrimental issues of malnutrition and sarcopenia, as well as what typically brings a patient to our office: gastrointestinal symptoms and distress, including steatorrhea. Long-term effects, along with the micronutrient deficiencies, can be osteopenia and osteoporosis, and ultimately it can lead to significantly decreased quality of life. Sometimes people's bowel function keeps them home, doesn't allow them to work, doesn't allow them to go out due to its severity. So significant consequences across the board. So who's at risk for EPI? Who do we look for this in? That's one of the challenges, is that there are a long list of risk factors and associated conditions that make a person predisposed to EPI. So let's break them down into a few different categories. You have your pancreatic disorders. That can include acute pancreatitis, especially with extensive pancreatic necrosis or repeated bouts of acute pancreatitis, chronic pancreatitis, pancreatic obstruction coming from a pancreatic duct obstruction or calcifications, pancreatic cancer due to potential obstruction. It could also be due to destruction of the tissue that makes the enzymes, therefore less enzymes are being made. It can also come from pancreatic atrophy that can come from hematopoietic cell transplantation or due to immunotherapy, or sometimes it can be due to unknown factors. You can also experience it from surgeries, including pancreatic surgery. Anytime part of the pancreas is resected, there's less tissue to make enzymes, therefore there is risk for EPI, and gastrointestinal surgery. And I think this is an area of patients that are at risk for EPI that go unrecognized or under-recognized. And so that can include esophagectomy, gastrectomy, Roux-en-Y gastric bypass, gastrojejunostomy, and proximal bowel resection. Anytime that you're changing the transit of food into the small intestine, you're increasing the risk for EPI because you could throw off the synchrony between the enzymes and the food. So it's an important area to really think about and kind of dive into a patient's history because that could be affecting them in the present. And then you have your even more complicated category, your extra pancreatic disorders. Celiac disease, inflammatory bowel disease, cystic fibrosis, type 1, 2, and 3C diabetes, use of somatostatin analog treatment, often used in the treatment of neuroendocrine tumors, HIV, and cirrhosis. And so you can see it is a very lengthy list, and that makes finding EPI a bit more challenging. So how do you diagnose EPI, or how do you help the team to diagnose EPI? This is another challenge to finding EPI, is that it's primarily a clinical diagnosis. While there are a few diagnostic tests, they're not without their faults. And so it really does depend on an in-depth review of signs and symptoms. I encourage you, as you get comfortable with looking for EPI, to focus on patients with risk factors and associated conditions, as that's where you're going to see EPI most frequently. Speaking of those diagnostic tests, they can be useful to determine EPI, especially in those with conditions that are not commonly associated with EPI. So things like celiac disease, inflammatory bowel disease, and diabetes, where you just need a test to kind of make sure you're moving in the right direction. So these are the signs and symptoms of EPI. I suggest that you get really comfortable with asking a lot of questions about patients' stools and gas, because that's what it takes to find EPI in our patients. And so I just want to take a few minutes to go over the symptoms and what I typically look for are questions that I often ask. So when you think EPI, I'm sure you think right away steatorrhea. And you're exactly right. That is the common symptom of EPI. That includes bulky, pale, so tan, yellow, orange in color, foul-smelling, greasy, oily, and floating stools. What you want to keep in mind, though, is that steatorrhea typically only occurs in advanced EPI. So if you have a patient that has early EPI, they may not have overt steatorrhea. So you want to look for some of these other symptoms that we're about to talk about. The next is abdominal bloating. This can be tricky because it can come from multiple reasons, but EPI abdominal bloating typically comes from it typically presents as bloating that worsens as the day goes along. So there may be none in the morning, and as that undigested food builds up, it'll be worse at night. It may also come more after high-fat meals. So those are some things to look out for when patients are describing their bloating. Postprandial abdominal pain or cramping may worsen after meals and may also be described as gas pains. So those are some questions to ask, and typically the pain comes and goes associated with eating. The next symptom is loose stools. This can also, like steatorrhea, be a common marker of EPI, but keep in mind that if you have patients who are on pain medications or antiemetic medications that cause constipation, they may not have loose stools because of the side effects of those medications. So while you want to look for that, just because loose stools aren't present doesn't mean the patient does not have EPI. So don't think loose stools have to be present for EPI. And then you have your frequent or urgent stools, especially after meals. This is often described as I have to have a bathroom everywhere I eat. If I go out to a restaurant, I have to go right before I leave. And typically they're very urgent. So you find the bathroom or the patient has an accident. What's important to ask patients is how many bowel movements a day are they having? Because it can take a year or more for EPI to be diagnosed once the symptoms present. And so patients get used to having accidents, having urgent stools, going to the bathroom 5 times a day. So you want to ask them, like, how many bowel movements are you having? And when are they happening? Because we all know that 5 bowel movements a day is not normal. And we as dietitians are not happy with that. So you want to make sure that you ask those questions. Next is flatulence. And this will often increase as the day goes along as well because of that continued buildup of undigested food. It will also typically be very malodorous or extra smelly. I kind of think of it as if a patient was a cartoon and they passed gas with EPI, it'd be like a green cloud of smoke around them. And trust me, if you experience it once, you'll totally know what I mean. And then you have indigestion. Again, because that food is building up and it's undigested, it can lead to indigestion, typically that peaks after meals. And lastly, you have weight loss despite patients eating well. And you'll often see patients are really putting in the food and you're wondering where it's going. It could be EPI and they could be, putting it in the toilet instead of putting it in their body. So it's important to do a diet recall so you understand how much a patient is eating. Keep in mind that all of these symptoms worsen with higher fat intake and may improve with lower fat intake. And oftentimes patients are trying to fix themselves before they present to us. So they may already have adjusted their diet to have less of these symptoms. So it's important to kind of make sure you're understanding what they used to eat and what they're eating now and connect it to the symptoms. So now that you know you have to ask a lot of questions about gas, bloating, and stool, let's talk about those tests because you're probably thinking that would be a lot easier. So there are some tests available. There are direct tests of pancreatic function. They're typically reserved for studies. And in my 10 plus years of working in this area, I've never seen one of these results. The tests that you will see are indirect tests of pancreatic function. And they include the coefficient of fat absorption, or more commonly known as the 72-hour fecal fat test, which requires patients to eat 100 grams of fat a day and collect their stools for that period of time. That test can be very hard to complete. It can make a patient very uncomfortable. So it's not a test that you often see completed. You also have the qualitative fecal fat test, which is a spot test to see if there's fat in the stool. But that is limiting because you aren't controlling for the amount of fat going in, so you don't know how much fat should be coming out. So that cannot be used to diagnose EPI. And then the test you'll see the most often is called fecal elastase concentration. And that is, fecal elastase is an enzyme secreted by the pancreas that stays intact in the stool. And then can be measured. And it is sensitive in patients with severe EPI, but not as sensitive in mild to moderate. So can have its limitations and should be combined with a good clinical review of symptoms. So as you can see, there's no test that does the job to replace a clinical symptom review, but they can be helpful. So now that we know how to find EPI, we're going to ask all the questions. What do we do about it? That's one of my favorite things about caring for patients in this area is there's a lot we can do to help them. So the primary intervention is pancreatic enzyme replacement therapy, or PERT. Additional interventions may include a low-fat diet, but that's typically reserved for patients who have not seen improvement with PERT or who cannot use it. And then micronutrient monitoring is important with supplementation as needed, especially a fat-soluble vitamin. So let's talk a little bit more about pancreatic enzyme replacement therapy. It's the use of prescription pancreatic enzymes taken with meals, snacks, and oral nutrition supplements. The generic name is pancreolipase. And the pills are taken to mimic the function of the pancreas by providing amylase, protease, and lipase to mix with food in the small intestine. It aims to correct maldigestion and malabsorption and has been shown to do that in multiple studies. With adequate PERT, no dietary fat restriction is required. So really, PERT is there to mimic the function of the pancreas and replace the job that the pancreas just isn't able to do. So there are a few options for PERT. The preferred option is the prescription option, and they come in two different versions: delayed release capsules with enteric-coated microspheres so that the enzymes do not become activated until they get to the small intestine. This is typically preferred for most patients and the version you're going to see used most often. There's also a non-enteric coated tablet, but often requires to be used with an acid-reducing medication to protect those enzymes from breaking down. You'll also see a lot of digestive enzyme supplements over the counter at the store. Those are not recommended for the treatment of EPI because of the inadequate regulation of the supplement industry. The products are often not standardized, and typically the lipase dosing in those products is too low to be effective. So you want to encourage the use of prescription PERT. So how does it work? Let's talk about the enteric-coated PERT. So patients need to take these every time they eat something that contains fat. So meals, snacks, and oral nutrition supplements. And taking it at the start of the meal is important so that it mixes with the food as it goes through the system. The capsule dissolves in the acidic environment of the stomach and releases enteric-coated microspheres of enzymes. Those microspheres go onto the duodenum where they become activated in the alkaline environment, and they mix with the food in the small intestine to then digest the food. So it's important that patients take this medication properly so that this cascade of events can happen. So the next challenge in treating patients with EPI is dosing PERT. And that can be where things can go wrong. We want to make sure that we're mimicking the adequate amount of enzymes that a patient needs. And so dosing it properly is important. It is dosed by lipase unit, although PERT does include amylase and protease as well, because the pancreatic enzymes do so much work on fat. We always focus on dosing it based on the lipase. Several dosing methods available. We have your weight-based dosing, which is endorsed by the Cystic Fibrosis Foundation and recommends 500 to 2,500 lipase units per kilogram per meal, and half of that per snack. You have your meal-based dosing, which I personally find much easier than calculating, and it typically hits the right spot for most people. And for adults, that is to begin with 40,000 to 50,000 lipase units per meal, and half of that for snacks. And that's my favorite way of dosing, and that's typically what I utilize. I feel like it's easy, it's quick, it's reproducible for multiple clinicians, and it really gets people started on the right foot. You also have per gram of fat consumed dosing. This is my least favorite because I think it leads people to underdose because they underestimate how much fat they're eating. You do want to keep in mind that PERT dosing may need to be increased with higher energy or fat intake. The more fat that's coming in, the more enzymes that are going to be needed. It's important that you teach a patient how to utilize these medications appropriately. They should be administered at the beginning of all meals, snacks, and oral nutrition supplements so that they mix with the food appropriately. They are required for all fat-containing foods. Patients always ask about the side effects. I find that there are minimal side effects. One that patients may see is constipation, or less stools because they're absorbing their food better. And so that's something that I always am transparent about. They may also see changes in glucose levels because they're better absorbing their food. Other considerations is that PERT is derived from the pancreas of a pig. It's porcine derived. So that could be a potential issue for patients with a pork allergy or religious or cultural beliefs and preferences that limit the use of porcine derived products. When I am talking with a patient about PERT, I always let them know this right away so that they can be informed and make any necessary decisions regarding this medication. There are no non-porcine derived enzymes in the United States. So really, if you're using a prescription PERT, it is always going to be from the pancreas of a pig. You also want to make sure that you're educating patients appropriately. It's important to educate them on what is EPI, why are they having these symptoms, and why do they need pancreatic enzyme replacement. how do they take it appropriately? It's only going to work if they take it exactly as they have to, as you prescribed, as the doctor has prescribed it. And then what symptoms are they monitoring? What should get better as they start the PERT? And that there maybe needs to adjust the dosing down the line. It's not always easy to get it right the first try. And keep in mind, as a practitioner, routine follow-up is key because patients need additional education. They need adjustment in their dosing. They need reinforcement. And so don't recommend PERT and then never follow up with that patient. One, you'll never see how good they did. And two, they're not going to have the support they need to continue to be successful. So how do you know if it's working? You want to compare the severity of symptoms before and after. It's very important that you do a good job of getting the symptom recall and documenting it so you can do a comparison. The expected positive changes after PERT are improvement in all of any present gastrointestinal symptoms: stool urgency, frequency, and odor, diarrhea and loose stools. The stools should be darker. They should sink more than they float. They should not be oily or greasy. Patients in the long term may see an improvement in energy level, weight, and strength, and normalization over time and maintenance of fat-soluble vitamin levels after appropriate repletion. So you want to make sure that you know what should get better and that the patient also knows. So in summary, I hope you enjoyed our journey through the conversation about EPI. It can occur as a result of many and varied associated conditions. It results in detrimental gastrointestinal and nutritional side effects and can be very impactful on a patient's life. PERT, or pancreatic enzyme replacement therapy, is a primary intervention to address the root cause. RDNs can and should serve an important role in the identification, treatment, and patient counseling regarding the treatment of EPI, and I encourage you to get comfortable in this area and become more involved in the care of patients with EPI. Thank you so much for joining me.